Hello, my name is Sonia Hogue. I'm a clinical nurse educator in General Systems ICU at the University of Alberta Hospital. Please review this presentation to help you understand our unit and orientation process. Dr. King was a pioneer in critical care. I have not worked in the time of Dr. King, but our unit bears his name. Our unit has beds in multiple spaces. 3C2 has 4 intensive care unit and 4 high-intensity unit beds. 3C3 has 10 beds. 3C4 has 20 beds, and 6A8 in the Mazankowski has 8 beds. There are plans to move 6A8 to 5A8, and that space is being prepared. The number of open beds may change based on our unit and hospital circumstances. Feel free to screenshot this slide or refer to it later to find the contact information for the unit manager team and to understand our management structure. Cindy, Pete, Matt, Cody, Lisa, Allison, and Carmen are shown left to right. Our management team is accessible to you. While you will be assigned to one of our managers' portfolios, it is best to email all of them for your needs at their shared email to get timely responses from any team member. Carmen, Lisa, Cindy, Pete, and Cody are found in the offices in the management suite, which is at the intersection of Burns and ICU. Allison and Chrissy, the Burns educator, share an office near on the Burns side. Carmen is our patient care manager. Cindy, Lisa, Cody, and Pete are unit managers for ICU. Allison is the acting unit manager for Burns. Janelle Mudry and Debbie Morris are shown here. Janelle's on the left, Debbie's on the right. They are administrative assistants and are also in that shared office space with the managers. There is no need to knock on that door, just walk right in. They are so lovely. Left to right is Matt, Kelly, Chrissy, Sonia, Steve, Jenna, and Jessica. Matt is our clinical nurse specialist and is on the management team but directs the educators. Kelly, Jenna, Jessica, Steve, and me are educators for 3C3, 3C4, and 6A8. Chrissy is the acting educator for Burns. Chrissy shares an office with Allison, like I mentioned, on the Burns side, and the rest of us share an office in the back hallway. Matt's office is also in the back hallway. You will be placed in one educator's portfolio, but you can go to any of the team for help. Our shared email is shown here. We take care of a variety of patients with a broad number of diagnoses. Your skill set is about to broaden, and we are very glad to be on this journey with you. We have a large team which is composed of diverse people with many different roles. We encourage you to help people know who you are, and if you do not know who someone is, please ask. We have physicians who specialize in critical care. They also have other specializations. For example, Dr. Romanovsky is a nephrologist and an intensivist. Dr. Slegel is an infectious disease physician and an intensivist. And Dr. Witter is a surgeon and an intensivist. We always have 3 attending-led physician teams with another intensivist covering 6A8. We always have a dedicated MET intensivist. They are on service for 1 week starting on Mondays. As this is a teaching hospital, each physician team has a dedicated fellow. This means that fellow is a senior resident specializing in critical care who has almost completed their training, along with more junior residents who cycle through ICU rotations. In the mornings, the teams do rounds. Pharmacists also round with each team. Bedside RNs report their physical assessment and review any issues. Respiratory therapists usually also join rounds to discuss respiratory problems. Occasionally, due to workflow, they are kept away. Then it's the nurse's job. The resident assigned to the patient will lead the discussion on rounds, and on rounds, assessments, labs, plans, and updates are to be done. We also try to address families. This is when you can ask questions and clarify the plan of care. We strive to keep noise to a minimum during rounds to facilitate communication. You will find assignment information on the board by the front desk, and all the physician teams will be listed. Just like I mentioned, this is the assignment board, and it's beside the front desk. It's right inside the front doors of ICU. It lists all the beds and the nurses assigned to that patient in each room. Brief information like whether or not the patient is on isolation precautions is listed beside their names. Lines indicate doubles, and that's when a nurse takes care of 2 patients, and dotted lines show potential and future doubles. This board also shows who's on code, met, and who does the Pyxis count at every shift change. The charge nurse and unit clerk are at the top of the board. The physicians are listed, and the X beside their names indicate that they are on call. The physicians are also grouped into teams by color, and you'll notice your patient's name is in the corresponding color at your bedside. Lastly, the healthcare aides are listed with their phone numbers beside their names. Anytime you are on our unit, we want you to know how to get help and get help quickly. The staff assist buttons are above the large counter and on either side of the bed at the head of the bed. Make sure to push the buttons indicated. Please do not pull the cords. You are encouraged to use your voice, the emergency buttons at the head of the bed and the counter, and the in-room phone to get the urgent help you may need. Remember to communicate what you need when help begins to arrive. To succeed in our orientation program, you will go through a combination of online and unit-specific learning. We also have unit-specific learning that you will do on your own time. That's kind of like right now. We then have a pre-OPACCA day where we will meet for the first time here on the unit. That includes a tour, introductions, and a skills lab. The formal learning of critical care concepts is done on a provincial level through the Orientation Program for Adult Critical Care in Alberta, also known as OPACCA. This program is done online and is taught by a group of educators from the entire province. You also have integrated clinical shifts throughout the OPACCA program. That's when you come to the unit. These days usually involve some part of the day being at the bedside, buddied with a nurse, gaining familiarity with our unit and processes, and some theory and practical learning here on the unit. Once you have written the final evaluation for OPACCA, we have a post-OPACCA day here on the unit where we do practice scenarios and we go through common issues that you might run into right away in your independent and buddy practice. After that, you move into 15 or more buddy shifts. You will, through these buddy shifts, have a midterm and final evaluation and then move into independent practice. Sometimes gaining skills is called clinical laddering, and you are now part of the General Systems ICU Fellowship. This is new. This means we're creating a program that takes the view that becoming experts in ICU takes time, and therefore your orientation should have a year-long plan and then milestone learning for years to come. So you will receive additional learning at staggered points within your first year. As soon as possible, we want to ensure you have your foundational skills in nursing. As mentioned before, after your theoretical learning, you will go into buddy shifts and then independent practice. At 3 months, you will receive enrichment in trauma care and end-of-life care. At 6 months, you will receive learning on more advanced ICU concepts. Then at 9 to 12 months, you will be certified in ACLS and be on the code team. After you've gained some of those really important foundational and moderate ICU skills and more advanced skills, we know you need time to practice that. And then at year 3 to 4, or the equivalent full-time hours, you'll be trained in continuous renal replacement therapy. And approximately 1 year later, you'll be trained in intermittent hemodialysis. Training for intraoperative CRRT, it's okay if you didn't know that existed, occurs after you are comfortable with CRT on the unit. Training to be on the medical emergency team occurs after about 3 to 5 years. Your skills advancement should be discussed regularly with your unit manager and CNE. Don't worry, charge training will not occur until approximately the 5-year mark, and charge training is at the management's discretion. Before you enter the unit, we need to cover some basic safety principles. Remember that we use the REACT acronym to help us remember what to do in the event of a fire. Protective services can be accessed only through hospital phones with 10 pound. The protective services phone number can be dialed from any phone. And if you would like, you can store it in your phone to have at the ready if you need it anywhere on AHS property. Protective services can help us apply restraints, help us with patients who are legally required to stay in the hospital. They can help us with escalating situations, and they can provide protective equipment if we have medically necessary reasons to look through a patient's belongings, or a patient asks us to look through their belongings and you're maybe a little bit nervous that something might be harmful in there. Additionally, protective services will walk with patients, families, and staff to their vehicles if they want and ask for it. Just be sure to let them know as soon as possible so that they can plan their day and you're not waiting. Our goal is for you and our patients to be safe. We can be perfect with donning and doffing, so we should be. If there is uncertainty about isolation, talk to your charge nurse and physician team. Signage matters, so if you have a patient on isolation, but a sign is not in place on that patient door, how are other team members meant to know about isolation? Signs keep people safe. Aerosol generating medical procedures require increased personal protective equipment. Even if a patient is not on isolation or is only on contact precautions, aerosol generating medical procedures will require an N95, eye protection, a gown, and gloves. If you have a patient with some sort of bug, virus, bacteria, and you're unsure of whether they must be isolated, you can find the Infection Prevention Control Manual through your chart. Under Resource Links, scroll down to Infection Prevention and Control. Hitting that link leads you to this page on Insight with all things infection prevention and control. If you follow the first link, you will go to the IPC Acute Care Resource Manual. In this manual, you can use the alphabet links on each page to find resources for a host of afflictions. For example, if your patient has lice, you can click on lice. And then you will link to find all the information you need. Ask an educator, unit manager, buddy, or charge nurse any PPE or isolation questions you have. We want you and our patients to be safe. If you have questions about what is to be done for any type of waste, look up and see the signs in the dirty utility rooms. In brief, sharps go into the designated sharps containers, black bags take general garbage and waste, yellow is for biohazardous waste, and red indicates cytotoxic waste. Spill kits for hazardous medications are in the medication rooms. There are indicators that are measured to ensure that we give the best patient care we can. For example, Liberate is an initiative which gives direction on how to lessen the time it takes for patients to be liberated from the ventilator. And Skin is an initiative to limit pressure injuries. Additionally, we track hand washing statistics, so do not be surprised to see these reports on the quality board near the entrance of ICU. Like I mentioned, the quality board, which is pictured here, is near the entrance of 3C3 and 3C4. You will see safety and quality trends communicated here. You must be familiar with the standards of care for our unit. There is a quiz which you should have completed by the first day you come to the unit, that pre-OPACCA day. We ask you to do a quiz to help you thoroughly review these standards. It will be challenging to meet our patient care standards if you do not know them, so please read them carefully. This is challenging work, and how you feel matters. Please make sure that you protect yourself and your relationships by prioritizing your mental health. We have an early career support squad where you can connect with coworkers away from work who are having similar experiences. We have a Facebook page for communication, mainly used for trades. We also have an Instagram account called CNE Info, where you can connect with information and social events. Remember that we can access the Employee and Family Assistance Program at any time. Also, our Blue Cross benefits have $3,000 allocated for psychological services. Make sure you take steps to stay well. Social Connections will vaccinate you against psychosocial distress, so please make time for people and things that you care about. Lastly, ask anything whenever you need to. Please know that there are no stupid questions. This completes the presentation. If you have questions, comments, or concerns, ask when you see us, or you can also email us anytime here in the education office with the shared email listed one more time. Thanks for listening, and see you soon.